Good evening. It's my great pleasure to have the last presentation regarding unusual presentation of multiple myeloma. Everybody knows that many years ago I focused on not typical presentations of multiple myeloma. Everybody knows what is typical presentation, and regarding this 5 years ago, we published a book collecting 100 multiple myeloma patients. The book's name is All Phases of Multiple Myeloma. It was published connecting to Polish 100th anniversary of the independence. And we collected the group of people which have a lot of symptoms. Nobody myeloma patient is the same. Everybody knows that, for example, stomach cancer or lung cancer has this very similar symptoms, and myeloma is so fascinating because everybody is different. And I would like to dedicate this lecture to Professor Ludwik Hirschfeld, who is also connecting to Serbia. He has a statue in Serbia, and we are planning to organize a plaque to commemorate this very famous professor of blood in Warsaw, together with Professor Jędrzejczak and Professor Skotnicki also. And he was a very famous guy, but this is not historical topic. So my topic I would like to share in 8 parts. First, I would like to show you some data about primary double refractory myeloma. Later, it's a very unique situation with central nervous system in multiple myeloma. Later, I would like to focus on very young patients with myeloma. Later, according to new definition in myeloma, MGRS is also touched. I would like to share data 6 years ago we published with Jorge IgM, multiple myeloma, also very unique translocation 14-16 myeloma, hot topic, and extramedullary disease and POEM syndrome. But before this, I would like to show you this slide which shows us the unique situation in this disease. Last 20 years, and we have exactly 19 new drugs, and 2 new drugs, elranatamab and talquetamab, was registered in last month. So this is incredible. First topic, it's primary double refractory. It was a paper published 3 years ago in leukemia and lymphoma. We focus on 85 patients, which is primary refractory, and this is a definition of this situation. It was published a couple of years ago by Vincent Rajkumar. This is disease non-responsive in patient who has never achieved minimal response or better. In this paper, we collected 85%, and everybody knows that patient is responding on therapeutics like bortezomib and lenalidomide, but about 10–20% could be refractory. And this study was to evaluate the situation. It was done according to 17 centers in the world. Refractory to IMiDs and proteasome inhibitors. This is a study population. You see 85 patients, and it was done in Europe, mostly VTD. It was typical induction, and in the United States, VRD. Second line was, it depends on the country, of course. This is the overall response, and the take-home message is very important in this disease. The immediate transplant in this situation is the better choice, not to do salvage therapy and do the immediate transplant. The summary is very simple, that primary double refractory patients may achieve maximum benefit from immediate transplant. And this is the proof also done a couple of days ago. This is a paper, very nice paper, published from Mayo Clinic. They collected more than 1,000 patients, and this was in the era of triple and quadruple induction therapy. And the summary is very similar like from our publication. From this area on quadruple induction therapy, only 6.7% are refractory to this disease. And the take-home message is to do as soon as possible autologous transplantation, not to do other salvage therapy. So also very rare situation. It was a paper published a couple of years ago in American Journal of Medicine. We completed 172 patients. It's still the biggest number in the world with this involvement in multiple myeloma. You see that central nervous system is very rare. I asked Jorge today about big Neal syndrome. It's also very rare in Waldenström disease. Patients has typical neurological defects like changes of vision, radiculopathy, headaches, etc. And the multiple myeloma has lesion, leptomeningeal disease, presence of monoclonal plasmacytoid CSF. This is the characteristic of these patients. It was done in 20 countries in Europe, Asia, Australia, and America. And the take-home message from this paper is that this is very severe situation, and the overall survival for this patient is only 6.7 months. So this is still unmet need in multiple myeloma. How to treat these patients? This is the answer here. The best situation is to give systemic therapy and also radiotherapy. It should be the best situation. Everybody knows that multiple myeloma, the normal span is, normal age is like 70, 75 years. But also we see last years very young patients. And we publish a paper focusing on this. We publish a paper, 52 cases, patients under 30 years old. And also we compare patients between 20 to 40 and between 40 to 60. In general, a very young population has less comorbidities, and of course it's eligible to all transplantation. And it is characteristic of this group, 52 people. And as you see, this is interesting that osteolytic lesion is more common than other, and LDH is also so probably this is very high risk situation. And the 5 years overall survival is quite nice, as you see, 77%. Almost 40% is in CR from this analysis. The summary is here, a prognostic maybe at least as good in general population of myeloma, probably due to novel agents and autologous transplantation. Very young patient has more frequently ISS1 and light chain disease, and predictor factors we didn't find. And this is the two cohort comparison, very big numbers, because we collected 916 patients, the cohort between 40 and 60, and 173 patients. To be honest, the most cohort was from Sweden. They sent us a lot of patients. I will not focus on this. I will go to this situation that all patients were treated with novel agents, of course, and patients who are younger, they are doing better than older. This is the predictors of survivals, age and ISS, of course. And prognosis, probably patients, and this is important, that patients younger had better survival than older. This is from our papers. Another situation is MGRS. It was a paper published a year ago. Also multiple centers from 20 countries, patient diagnosed between 2003 and 2020. And the diagnosis of MGRS was proved by hematopathological confirmation renal biopsy. And this is pathological diagnosis included amyloidosis, monoclonal immunoglobulin deposition disease, and other rare situation. And this is our group. It was 331 patients, and we divide not available was 51. Patient with confirmation was 280, and some patients were not treated and some patients were treated. And this was MGRS amyloidosis and also rare situation non-amyloidosis. This is the underlying diagnosis and the characteristic of this group. The first-line treatment, of course, it was probably the most important proteasome inhibitor-based therapy and also chemotherapy and image-based therapy. The result was like here, hematological and renal response, and overall survival was quite nice, 121 months. And patient with non-amyloidosis MGRS had better survival than amyloidosis MGRS, so it was significant. This is a summary from this paper. Amyloidosis is the most prevalent type of MGRS, about 70% of all cases. Monoclonal immunoglobulin deposition disease is the most common type of non-amyloidosis MGRS. Most patients receive treatment, more than 80%. Proteasome inhibitors regimen were the most commonly used. Hematologic response didn't always equal to renal response. This is a paper published 6 years ago with Jorge Castillo. It's a very rare situation, also IgM multiple myeloma. It's like 1% of all cases. Diagnosis require presence of IgM and more than 10% plasma cells in the bone marrow, and the presence of osteolytic lesions or translocation for 11-14. And Waldenstrom, as you heard, has very similar symptoms. This is our group. It was 131 patients. This is typical here. Some patients were diagnosed before 2000, some patients later. And the first-line treatment, typical proteasome inhibitors, IMiDs, chemotherapy. And we found some prognostic factors. This is very interesting that age is prognostic factors, ISS, and female. As you see, sex is very important in this situation. It was, for us, surprise. Patient with IgM myeloma treated similar to patients with other isotypes. And women age more than 70 have significant shorter overall survival than other cases. Another point is translocation 1416. It was my PhD student, Sarah Goldman, done this publication published in American Journal of Medicine. This is rare situation, of course. This is like 5% of multiple myeloma. It's very high-risk patients. We collected 223 patients, typical first-line treatment, and this is overall survival estimates translocation 1416. So this is, we prove that translocation 1416, every patient could have renal failure, and no, this is high-risk abnormalities. Another situation is extramedullary disease. We know that it could happen, of course. This was a trial conducted in 15 centers. This was new diagnosed 127 patients with focus on hematological extramedullary disease. Patients' median time to this situation was 32 months. This is the characteristic of this group, typical situation. And sites of this rare situation is like here, breast, liver, gastrointestinal, soft tissue like skin it could also find. And the median survival from this situation is also very poor. It's only 6.5 months. So this is still unmet need in this situation. This is the summary treatment. Upfront autologous transplantation postpones this situation. IMiDs are the time provide deeper response than proteasome inhibitor chemotherapy. High-risk cytogenetics, increased LDH, shorter time to diagnosis to heme localization. And last point is POEMS syndrome. It was published this year. It was a collection on 108 patient multi-center analysis. And according to our situation, our results, we know that POEMS syndrome is, of course, very rare, but autologous transplantation still probably is the best treatment in this disease. The spectrum of rare clinical situation is very broad. We focus on only some points. We can find also myeloma IgD, myeloma IgA, a very rare non-secretory multiple myeloma, plasma cell leukemia, and others like family myeloma. Regarding plasma cell leukemia, it's very interesting. I'm doing revision at the moment, the paper from China, where they collected 340 patients. This is the biggest number in the world, and they prove that we published it 5 years ago, that low platelets, high cytogenetics, and it was more than 5% plasma cell in the blood. It's the highest bad situation for this. So this is the summary. It's still challenge that rare manifestation of myeloma, the lack of valid level and scientific knowledge which leads to difficulties. Biology, it's rare and heterogeneous, and it's still unmet needs. Treatment, probably it's similar like others, but we need to focus on personalized medicine. And I hope that in one day we will cure myeloma, and this is people who are working on this, and I'm happy that this international group who are coming to Krakow this year will help in this task. Thank you.
Thank you very much, Artur. Again, thanks for all speakers who came even from South America to Kraków, and multiple myeloma has no borders. Artur is a good example as a person who cooperates with whole world, and I'm sure that with all of us are working on that, sacrifice our time, our energy, and it's so good for patient with multiple myeloma. Already we have some patients living for 10, 15, even 15 years with multiple myeloma. So it's great achievement as compared with 2-3 years, as I remember 50 years ago.
It's example of functional cure. 10-15% can live only after autologous transplantation. One guy is here, Professor Żuchowski. He has transplant exactly 15 years ago, and he has no other treatments. So it can happen.
Okay. So I'm thinking that we will be closing our tour.
Maybe question?
Perhaps somebody would like to add another phase of multiple myeloma, which Artur didn't notice yet. But if no, I think we had a very good working day.
One question.
One question.
Yes, thank you very much. Artur, there is no cancer, no neoplasm in the organism with functioning immunological system. Then in such young people developing multiple myeloma, what, in your opinion, what kind of factors, epigenetic factors perhaps, would influence the developing in such unusual age?
It's a very good question, and in our paper published a couple of years ago, we have only 52 cases, and I have the feeling that young patient has worse situation, worse cytogenetics, like translocation 14, 16, etc. And in this group, it's elevated LDH was almost 50%. When I start treatment patient who is at the moment 30 or 35 years old, it's a big challenge because, of course, we are treating the best form of therapy like DARA-VTT or DARA-VRD and autologous transplantation. But we are thinking that it will be some functional cure, but it will be not. Sometimes patients is relapsing, and maybe I hope that immunotherapy, it will be some nice answer for such patient. At the moment, we have a lady, she's at the same age like me, 52 years old lady, and she's at the treatment 6th line of therapy, and I keep my finger crossed because we gave her teclistamab, and I hope it will work. She's refractory for all treatment.
Beautiful statement here. We will cure multiple myeloma, so I hardly believe all, but we are even now able to cure some patients with multiple myeloma, and as you said a while ago, using immunological power. So it's immunological therapy if you do allogeneic transplant. So the problem is to have a low tumor burden when you apply allogeneic transplantation, not to do it as a rescue with big tumor. You will always lose this patient, but you have to prepare patient for allogeneic transplant using all measures, especially all these fascinating new drugs. But to prevent from relapse, you have to do allogeneic transplant. Then the question arises whether it's ethical or not, because, you know, if you look at some statistics, the mortality rate is something warning. Nevertheless, I think we made big progress, and I think that we are very, very near the time when we will refer multiple myeloma patient in right time and cure them using allogeneic transplant.
10 years before, I will agree with you, but we are at the moment in 2023, and to be honest, when you ask such question in Greece, in Ireland, UK, I think it will be not so many candidates to do allogeneic transplantation. Why? Because it's still 10% of transplant-related mortality. This is the real data. And we have 19 new drugs, and to be honest, when I have myeloma at the moment, I will not do in myself allogeneic transplantation. I will try to find other solution like CAR T cells, etc. Because 10% of transplant-related mortality, it's still not ethical.
I looked in the morning at the recommendation of the American Society for Transplantation and Cellular Therapy. So they advised to do autologous transplant as a regular procedure, but concerning allogeneic, they say it should be done within trials, so yeah, registered cases. And I think this is the point.
Trials, it's good.
In case of young patients, it is unethical not to give them chance to be cured. And at the moment, the only one procedure is allogeneic
as
transplant.
We have heard today, graft versus myeloma, which is exemplification of allogeneic is now optimized by CAR T cells, which are less toxic, more specific. So anyway, thymus-dependent T cells, as I used to say, are our hero, our tool to fight against so many cancers. And I am so glad that my successors, like ARTUR JURCZYSZYN and other colleagues, could have such good results. Anyway, thanks very much. As a co-chairman with my colleagues, I thank you very much for your patience. And I am I'm sure ARTUR will have some administrative notes. So thanks very much for coming to Kraków. And last 2 words for ARTUR JURCZYSZYN.
So, yes. Thank you. Thank you. Thank you for coming to Krakow, and I think this was 11 international conference. It was the most international because we represent 9 countries from many centers also, and I hope this statement will cure myeloma in 10 years will be true. We are trying, of course, we are doing the best. And I'm sure last month we are at the moment 2nd of September and exactly 19 of August and 22 of August it was registered 2 new drugs. For patients it's new tools. I know that some patients are here on this place and they are waiting for the cure in myeloma. I hope we will find the cure. And thank you for coming to Krakow, and I invite you to a nice restaurant in nice district on Krakow, in Kazimierz. This is the restaurant in Estera. This will be the part of our topic continue there. Thank you very much.